Okay, thank you very much. Now we're moving to the next session, which is about infectious diseases. My name is Dr. Jihad Abdullah. I am an infectious disease consultant at SKMC Al-Rahba Hospital in Abu Dhabi. And it gives me a great pleasure to introduce our first speaker, Professor Xavier Corbella from Spain. Dr. Corbella, or Professor Corbella, is the head of internal medicine department at Catalan Institute of Health in Barcelona, Spain. He's also the vice dean, School of Medicine at the Universitat Internacional de Catalonia in Spain, and also he is the Secretary General of the European Federation of Internal Medicine. And Professor Corbella will talk about the relation between the inflammation and the outcome of the COVID-19 disease. Dr. Corbella, the floor is yours.
Good morning, ladies and gentlemen. On behalf of the Executive Committee of the European Federation of Internal Medicine, I want to thank the organizers of this annual meeting of the Emirates Society of Internal Medicine. These are my positions. I'm Xavier Corbella. I'm the head of the Internal Medicine Department at Belvitge Hospital in Barcelona, Spain. And also I'm Vice Dean of the School of Medicine in the International University of Catalonia. And I'm the current Secretary General of the European Federation of Internal Medicine. This is a historic picture that we took 1 year and a half ago when the Executive Committee met in Malaga to prepare the next Congress of the European Federation of Internal Medicine that was to be held in March of 2021. It was in February and was only 1 week before the eruption of the pandemic in Europe. When Nicola Montano, that was the current president, came back to Milan, he saw all the hospitals collapse and alerted us that the pandemic was arriving to Europe. And 1 week after, we diagnosed the first patient in Barcelona. After that, we met only virtually, and this was a very sad situation. Of course, all the world was in this same situation. And the situation in Europe was, excuse me, was this: the rank of countries has been United Kingdom, the country with more cases infected. Russia, Turkey, France, Spain was in the 5th position. Italy and Germany were the countries in the top positions. Currently, in October 21st, is different. We suffered several waves, and now these countries are in lower rates of incidence, but still in the Western countries of Europe, there is a high incidence of infections by the SARS-CoV-2. This was the situation in Spain. We lived 5 waves. The first one, the second one, the third one, the fourth one, and the 5th in this summer in August. Of course, the number of cases diagnosed was higher, but the severity, the mortality was lower. So we managed quite well the disease, but the first wave was the more dangerous, and as other parts in the world. The pathogenesis of the COVID-19 is well known now, but at the beginning was not so clear. We have 3 stages. The first stage is the viral response phase. The second is the pulmonary phase. And the third is the hyperinflammatory phase, when the storm of cytokines are damaging several organs of the patient. So the most important thing for us from hospitals was to detect since the beginning, since the arrival of the patient in the emergency department, who of them are at higher risk to transit into the most severe stages of the disease. And this was what we did. We have only as a clinicians, we have only the clinical symptoms and the clinical signs to manage at the beginning and to decide which patients are at higher risk. So we decided to perform 2 studies to publish in a journal of clinical medicine. And this was very important to decide the treatments that in every stage the patient needs. Of course, as all the world, at the beginning, we treated patients with chloroquine, hydroxychloroquine, ritonavir, lopinavir that now are not indicated. But remdesivir and the most important, all the drugs with immunosuppressors that can help patients, you have to decide when to administer to the patient. So our interest was to detect the risk factors in predicting bad outcomes, and bad outcomes understood as, of course, in hospital death, but also the need of the high flow nasal canal oxygen, the non-invasive mechanical ventilation, or invasive mechanical ventilation, or admission at the ICU. These are considered the bad outcomes, and we wanted to detect which patients upon arrival have the risk to progress to transit to these most severe stages of the disease. So the 2 studies were performed on the basis of a Spanish registry, the Spanish registry of semi-COVID-19, and one was more clinical to define, to detect, to determine which clinical phenotypes present the patients, determining and predicting mortality. And the other was on the basis of laboratory parameters, which patients with risk categories help the physician to detect those patients at higher risk for mortality. The registry is the semi-COVID-19 registry, was promoted by the Spanish Society of Internal Medicine. Involved more than 150 hospitals. Essentially, hospitals send the cases of the first wave, the most dangerous. So the registry include the study period from March the 1st and July the 31st. This was the curve. And as outcomes definitions, we have the primary outcome of in-hospital mortality, but the need of different supports of mechanical ventilation or oxygen or ICU admission was the secondary outcomes. The first article, the first study was the clinical demonstration of different groups of patients presenting differently at the hospital. And we finally detected 4 clusters that were with different prognosis. The first cluster was those patients, of course, presenting with fever and cough and dyspnea, but the most determinant for the poor prognosis was the dyspnea and the respiratory difficulties. So this group was those patients that arrived to the hospital with severe respiratory damage, and this has, of course, the poorest prognosis. Another group was those usually women that present with anosmia and ageusia, that this group of patients have better prognosis. So those patients presenting with anosmia or ageusia and headache was frequent and a better prognosis. Another group with better prognosis were those patients presenting at the hospital with a flu-like syndrome, arthromyalgias, headache, lower fever, sore throat, and this was another group of patients with prognosis. And last one, the C4 cluster, was those patients presenting with abdominal symptoms, diarrhea, vomiting, abdominal pain, that these patients have poor prognosis as well. These are the Kaplan-Meier curves showing the survival trends. And you can see that the cluster 2, that is those patients with anosmia and ageusia, has the better prognosis. The flu-like syndrome, COVID-19, was the second in better prognosis. But those with vomiting, diarrhea, and abdominal pain, or those with respiratory failure, are those with poor prognosis. The second study was to try to identify the risk categories in the determining mortality according to the inflammatory parameters that you detect at the day of admission. This has been a huge work with more than 70,000 patients, and we divide it in 3 categories: the low risk, the intermediate risk, and the high risk. Those patients presenting with these 5 parameters: lymphocyte count, CRP, LDH, ferritin, and D-dimer, with lower parameters, with better values, are at low risk of presenting mortality or bad outcomes. Those patients with one of these criteria, 1 or 2 or 3 criteria, belonging to the highest tercile of inflammation, are those presenting poor prognosis and were classified as high risk category. And the intermediate risk category was defined when the conditions of low or high risk were not met. These are the 3 groups: those patients presenting with good parameters, those patients with intermediate inflammation parameters, and those with high inflammation, that we decided to analyze the general data. And of course, those patients presenting with higher inflammatory parameters were those older, were in a greater proportion men, and have moderate severe degrees of dependency, and also have usually more proportion of underlying disease as chronic heart failure, chronic liver disease, etc. Attending the clinical symptoms, those patients with lower risk, with low inflammation parameters detected on arrival, was those with anosmia, ageusia, mimicking the results of the cluster clinician clinical phenotypes. So those patients that have anosmia, ageusia, or a flu-like syndrome usually present at the hospital with low inflammation. But those presenting with respiratory symptoms or abdominal pain or vomiting or diarrhea usually present on arrival the worst inflammatory parameters. These are the median of each value. The article is published, so you can go and have more information there. But as an example, those patients with a low risk present a median of lymphocyte count of 1,600. The intermediate group present 1,100, and the high risk were lower counts of around 800. And this was so on the other values. Another interesting thing was the perfect correlation of those patients presenting on admission with higher inflammation were those at higher risk to present bad outcomes, to need the use of high flow nasal cannula oxygen or mechanical ventilation, invasive or non-invasive, or ICU admission, or of course in hospital death. These are the Kaplan-Meier curves, and were clearly different. Those patients presenting at the hospital with low risk parameters have better prognosis. Those with the intermediate risk category was intermediate, and those with worse bad outcome were those presenting with high inflammatory parameters on admission. We also determined if the alteration, the abnormal parameters, were only 1 or 2 or 3 or 4 or 5, and were a clear correlation. Those patients only presenting one criterion of inflammation have a better prognosis than those that all 5 inflammatory parameters were abnormal and showing higher inflammation. Was the perfect correlation in the Kaplan-Meier curves. Additionally, we decided to perform a multivariate analysis, and we showed that those patients presenting on admission with higher inflammatory parameters have seven-fold more risk to present a bad outcome, either death or the need of ICU admission or mechanical ventilation. So the conclusion is that we have the present study identifies the three risk categories. The in-hospital mortality was based on these degrees, and is very easy to perform this analysis the day of admission. And doctors with this early identification and appropriate clinical management based on this risk stratification strategy could be more able to improve prognosis of these patients requiring different treatments or in advance support of oxygen. So this has been my talk. This is an image of the Thursday that we decided to confine the service and the hospital. It was an image, a historical picture of my team. It was on March of 2020. And since then, we have been treating and studying a lot of this very difficult disease. Thank you for your attention, and I will be able to respond any question or answers if you want.
Thank you very much, Professor. Any question from the audience? Okay, I'll start with one question, if you don't mind. D-dimers as a risk factor for poor prognosis, was it related to developments of thrombotic phenomenon or just as an inflammatory marker?
Very good question. First of all, thank you for inviting me. We had the same question, and we performed an additional study to try to see if those patients with higher D-dimer presented objectively thrombotic problems. And our conclusion was that, of course, it's an inflammatory parameters, for sure, but those patients that see a change, an evolution of this D-dimer, not according to the other parameters of inflammation, is those that you have to suspect that had a thrombotic problem in addition. We published this in the PLOS One, and our practice is to follow all these parameters, and if we see that the D-dimer goes at the same time of the others, no problem. But if the D-dimer changes differently from the others and evolves increasing, these are, in our case, experience that are the patients that in addition present thrombotic phenomena.
Okay. Any other questions? Okay.
Yeah, thank you, Professor. As you mentioned, the severe lymphopenia and it was related to the higher mortality. Did you get a chance, or anybody that did we give anything to increase the lymphocytes or white cell count, decrease the mortality, or anything like
that? We have no experience in this approach. Sincerely, we considered, of course, that this is an additional problem of these patients with low lymphocytes count. But my experience is focused on the hospital wards, not in other critical care areas. And in our experience in the hospital wards, we didn't use any drug to try to increase the lymphocytes.
Okay, one last question. Those inflammatory markers were the one you linked to the poor outcome. Those studies were before the recovery trial from England when they decided that steroids has a role in decreasing inflammation in the late phase of the disease and improve mortality, or after? And would it change in your anything in your study? And conclusion.
Very good question. Yes, the study was focused on the first wave, finishing in July 2020. That was the same date that the World Health Organization decided to non-indicate the other treatments, that hydroxychloroquine or ritonavir, and promoted and establishing that dexamethasone was an option. Of course, we decided to treat these patients when we saw our results from the beginning with different regimens of immunosuppressors. We started very early in March, April, treating with corticosteroids and with especially tocilizumab. Without any other support that those observational studies that were publishing in this emergency situation. But this was the part of the study that was done in this area. And I am sure that I agree with you that if this study has been performed now, most of these patients that arrive with a high level of inflammation, most of them will be treated with immunosuppressors or dexamethasone, and the poor outcomes has been changed dramatically. So yes, this has been the period that still was not a conclusion from the international guidelines. So the importance of this study is that we have the demonstration that if these patients are not treated with immunosuppressors, these patients have a higher risk of mortality and justifies the indication of dexamethasone or other immunosuppressions in this phase of the disease.
Okay, thank you very much, Professor. It was very nice having you today.